Good morning, sir. Good morning, everyone. Today I'll be doing a case presentation. The patient is a 55-year-old male teacher, resident of
You
Tumor.
have to go to this thing, what you call, you need to do a show rather than present this slide view, which is for editing. Please go to that point and press it. Let us see if it becomes over.
Okay, sir.
Because we can't see anything.
Okay, sir.
And this is better.
Sir, now you can see, sir.
You have not pressed that button, the third button. Yeah, that one.
Now you are able to see.
No, it's not coming as a presentation, only slide view. That's okay. Go on. Now I can see what you're presenting. Go to the first slide.
Yes, sir. This one.
Yeah, it says case presentation, Dr. Krishna, senior resident, third year. Yeah, please start. Hello?
Sir, I'm starting. Sir,
Yeah,
the
please
patient
start.
is a 55-year-old male. He's a teacher, a resident of Tumor, Rajasthan. Came with chief complaints of generalized severe bony pains for the last 3 months. Coming to history of presenting illness, patient was apparently normal 10 years ago, at which he started developing generalized body pains, which were initially mild and relieved with oral analgesics. However, the pain has gradually increased over the next 10 years, but since the last 3 months, the pain is severe and continuous, and it is not only partially relieved with medications. And pain is also aggravated with standing and even working, and his quality of life is also severely affected because of the pain. The last 3 months, the pain is also associated with change in the posture of the patient and gait of the patient. However, the pain is not associated with the duration, nocturnal or diurnal variation is not there with the patients. And along with the pain, last 3 months, the pain is associated with the radiating of pain in the both lower limbs for the last 3 months. Other than that, the patient is not complains of any association of pain in the abdomen, no nausea, no vomiting, no loss of appetite or loss of weight, no hematemesis or bleeding PR or melena, no fever, jaundice, altered bowel habits, headache, visual disturbance, and breathing difficulties. Is only
Let us stop at this point.
Yes, sir.
Let us stop at this point.
Yes,
and
sir.
say what are your first thoughts about this history? What do you think patient is trying to tell you?
Sir, patient is saying that for the last 10 years, he is having bony pains.
So anything 10 years of bony pain, what would be the explanation?
Sir, some disease like rheumatoid arthritis.
No, you should think more in terms of osteoporosis. All the bones are tender, so it could be any of the osteoporotic diseases.
Yes, sir, osteoporosis.
And the other possibility of 10 years of metastatic disease is unlikely. You cannot say he has had metastatic disease for 10 years.
Yes, sir.
So that's not possible. Whatever it is, whatever is being secreted is causing some kind of change in the bones that is resulting in pain.
Yes, sir.
One of those conditions is malignant osteoporosis, say like from a parathyroid carcinoma.
Yes.
So he has been survived with a parathyroid tumor or a parathyroid malignancy. That possibility should be kept in mind. That's what would come to my thoughts first.
Yes.
Yeah, please go on.
Yes, sir. So other than that, he has only lower urinary tract symptoms in the form of increased frequency nocturia and increased straining for the last 6 months. Coming to his past history, sir, patient is having no comorbidities. He was operated in 2015 for bilateral renal stones endoscopically. However, we do not have any documents for the same. And he was operated in 2018 for pituitary gland tumor in SMS. His presentation is with headache and reduced vision, which improved following the surgery. And for the same, we do not have any documents and we do not have any biopsy reports also. He had history of trivial trauma 2 months ago. He just slipped his leg, with which he is having severe pain in the right lower limb. So that is the only significant history, sir.
Was it a fracture? Did you ask whether he could get
Yes,
up
sir.
and walk?
I'll come to that in the investigations. He was evaluated for the same, and there was no fracture found at that time.
Okay. Yeah, go on.
And the family history, the patient's own brother was also operated for renal stones at the same age. However, he did not give any history of malignancies in the first or second degree relatives. He did not have
What
any.
are you looking for under those circumstances? When you have a familial history,
Yes, sir.
what comes to your mind? What kind of things come to your mind?
Sir,
What kind of a thing would have a parathyroid tumor in
Yes.
2 generations or parathyroid hyperplasia in 2 generations?
Yes, sir. Syndromes.
Yeah, that we need to know.
Yes, sir.
And we also need to know what is the kidney function of this patient, because if renal function is affected, chronic renal failure also can cause parathyroid hyperplasia. And if this hyperplasia lasts long enough, you can get parathyroid adenoma or adenocarcinoma.
Yes, sir.
Either this way or that way, it could be true. So, renal function history, do you have any history?
No, sir, he did not give any
Except
other.
stones?
No complaint. Yes, sir. Other than stones, both brothers are operated for renal stones. Other than that, they do not give any significant histories.
Are renal stones genetic in history? Say, for example, oxalate stones or
Sir, medical
uric acid
diseases like
stones?
renal tubular acidosis are known to cause renal stones, sir.
Yeah, that is the rare condition. But even normal renal stones, it runs in the families. Father has it, brother has it, somebody else in the family has it, and you also have it. So kidney stones also run in families. You have to be cognizant of that fact.
Yes.
Yeah, please go on.
Coming to his personal history, sir, he did not give any history of any substance abuse. His sleep was disturbed over the last 3 months due to the pain. No, and it doesn't give any history of altered bowel habits. Shall I summarize, sir, now?
Yeah, please summarize.
Sir, he is a 55-year-old teacher without any comorbidities and who was complaining of generalized pains for the last 10 years. Sudden increase of severe pain in the bony pains for the last 3 months. And along with that, patient also, with a positive history for operation for bilateral renal stones in both the patient and patient brother, and operated for pituitary tumor in 2018. Yes, and no other positive history in these patients.
So, was he? Did he gain weight? Did he look on your general examination? Did he look very fat with a round moon-like faces?
Sir, actually, patient is having.
Was there pigmentation? Yeah, okay. So he is acromegaly.
Yes, sir. Features of acromegaly.
So you have a pituitary tumor, you have renal stones. So what syndromes come to your mind which could include both a pituitary tumor and a renal problem?
Men's syndrome, sir.
Yeah, so automatically any surgeon would think of Men's syndrome, and Men's syndrome type 1 seems to be the more likely.
Yes, sir.
Because we have parathyroid adenoma and we have pituitary tumor.
Yes, sir.
So triple syndrome is more likely. Yeah, go on. Now we can start this general examination.
Yes, sir. General examination, patient is examined in supine and standing position. He is conscious and coherent, well-oriented to time, space, and person, with ECOG of 2 and BMI of 26. Patient had clubbing present. Other than that, no pallor, icterus, cyanosis, or pedal edema is seen. The face is prominent.
What is the cause for the clubbing?
Sir, the patient is having acromegaly features. One that.
So in acromegaly, you can get clubbing.
So, dermatosclerosis is seen in these patients, which looks like clubbing, sir. That is the description given.
Okay, go on.
Yes, sir. So, general examination, patient has a prominent cheeks, widened distance, widened nose and forehead. Chest is also barrel shaped, sir. Both hands and fingers are enlarged in this patient, and bilateral valgus deformity in the both lower limbs. Hemodynamically, the patient is stable on examination.
Okay.
Local examination, sir, and of the abdomen in supine position. The abdomen is scaphoid, umbilicus is central and inverted. No mass or fullness is seen, and all quadrants moving correspondingly with respiration. No scars, sinuses, or dilated veins. External genitalia and hernial orifices are normal. On palpation, abdomen is soft and non-tender, no palpable mass or hepatosplenomegaly, and no thrill. External genitalia and hernial orifices are normal. On percussion, the liver span is 10 centimeters in right midclavicular line, starting from the 6th intercostal space, no ascites, and normal bowel sounds on auscultation, no bruit. The distal rectal examination shown sphincter tone is normal, rectum is fecal staining is present, no bleeding or no blood or melena, no palpable nodules. Respiratory system, sir. Normal vesicular breath sounds are heard in both lungs, no added sounds. S1, S2 is heard, and no focal neurological deficits in the patient, and even the eye examination.
Does that include visual deficits?
No, yes, sir.
Have you tested for feet?
Yes, sir. I have checked it. No.
And feet are normal as far as gross examination is concerned.
Yes, sir. Grossly, no neurological deficits were present in the patient.
Okay, sure.
Including the visual.
Yeah.
So summarizing the history, sir, he's a 55-year-old male without any comorbidities. And
so you didn't tell us whether in the treatment history,
yes, sir,
whether he is on any pills after the removal of the what I call pituitary tumor. Was the pituitary entirely removed? Was there pituitary deficiency post surgery? That you will realize only if you realize whether he was on any treatment.
Medication. Sir, was he
on any treatment?
Sir, he is not actually on any treatment, and he was not even on follow-up, sir, proper follow-up.
Okay. But he has had no problems other than body ache in all this time.
Yes, sir. Other than that, he did not have any other complaints.
Okay.
Yes.
So at this moment, MEN syndrome is on the books.
Yes, sir.
And in MEN syndrome, we already had a pituitary tumor. Now we have a parathyroid tumor also probably becoming symptomatic.
Yes.
That's what comes to my mind so far from the summary and history. Do you disagree with that or do you agree with that?
No, sir, I'll agree with that.
Yeah. So, what is the difference between MEN1 and MEN2 and MEN2A and B?
Sir, MEN1 is pituitary tumor, parathyroid adenoma, and pancreatic tumors. While the MENS2A and 2B, MENS2A, it is medullary thyroid carcinoma, pheochromocytoma, and pancreatic tumor. While the MENS2B, it is medullary thyroid carcinoma, mucosal neuromas, marfanoid habitus, and pheochromocytoma. These are the features.
Okay.
Yes.
Go on.
So, shall I summarize the complete history, sir? Now?
Yeah, sure.
Sir, he's a 55-year-old male without any comorbidities and previous operative history of bilateral renal stones and pituitary gland tumor, operation for pituitary gland tumor, presenting with continuously increasing bony pains for the last 10 years and which worsened over the last 3 months, reducing his quality of life, and severe right lower limb pain with the trivial trauma, and wide features of acromegaly on general examination with valgus deformity in bilateral lower limbs, and essentially normal abdominal examination. Differential diagnosis for this includes a parathyroid adenoma. Most likely the patient is having a MENS1 syndrome.
Okay.
Yes.
Done. Anybody else disagrees? Anybody else has other possibilities?
But based on this history, can you say that it is a complete MEN?
Yes, sir. No.
What is the evidence of pancreatic tumor?
Sir, complete MEN we cannot, till now we just cannot, only on the history we cannot confirm it, sir. Complete.
Yes, you should say that.
Good morning, Dr. Kapoor.
Good morning, Rajan. Sorry, I'm a little late. So you can't say that it is, you have to say that it is incomplete MEN because you have evidence of only pituitary and parathyroid involvement. There is nothing to suggest pancreas involvement so far.
Yes, sir.
Carry on, Rajan, please.
Yeah, sure.
Sir, shall I continue?
Yes, please.
Yes, sir. So these are the blood investigations of the patient in our hospital. which have shown increased parathormone level, and presentation, the patient is having a calcium level of 13.1. Hypercalcemia was present for the patient, sir. And along with that, the serum creatinine level is 1.5, which is slightly more than the normal upper limit of normal in our hospital, which is 1.25. However, his anterior pituitary hormone levels were also evaluated. TSH was normal. Cortisol, follicular stimulating hormone, luteinizing hormone, and testosterone were also normal.
Okay.
His serum gastrin levels and chromogranin levels were followed up, sent in this patient, which have shown.
With what intention? Why did you want to check chromogranin in this patient?
Sir, follow up. This patient had been evaluated with X-ray imaging. I will come to those also.
Okay, so you know more than what we know.
You should have said that some imaging was done.
Yes, sir.
Imaging something, and then these levels were done.
Yes.
Otherwise, you would not do gastrin. You may do chromogranin because you know that it is associated with
the general marker.
Yes, sir. Chromogranin is general marker.
Neuro-Endocrine. But gastrin you will do only when you suspect. Clinically, so far, you haven't told us about any features to suggest gastrinoma.
Yes, sir.
What will be the clinical features to suggest or suspect gastrinoma?
The secreting gastrinoma, sir, usually the patient will have gastritis, gastroesophageal reflux disease, pain in the epigastric region, and diarrhea.
So severe symptoms of acid peptic disease, which is not responding to the usual dose and duration of anti-ulcer treatment, complicated peptic ulcer disease, and peptic ulcers at unusual sites. When you see all these things, you start suspecting. Here, of course, you have to suspect because the other two tumors are there. But otherwise, this is the situation where you start suspecting a gastrinoma. Yeah, carry on. So you should have said that these investigations were done only after something was seen on imaging. Yes.
Sir, so these are the images. The patient got X-rays of skull, C-spine, chest, bilateral upper limbs, and the lower limbs. The chest X-ray, sir, I do not have a pointer in this presentation for me.
Okay.
So I'll just read I'll tell the findings. In this skull, we can see multiple areas of lytic lesions, especially in the parietal region, where we can see some lucencies. And multiple small lucent areas is seen. This is a typical pepper and salt skull appearance.
Pepper pot appearance.
Sir?
It's called pepper pot appearance.
Pepper pot, okay. Pepper pot appearance. Okay. And even the C-spine and the upper chest, we can also see there are significant osteoporotic changes is seen in the C-spine. And in the upper chest also, where we can see the first rib, second rib, and third rib, in the images, what we can see, there are multiple lytic lesions, small honeycomb appearances in the medial aspect of the ribs, where we can see honeycombing type of appearance is also seen, suggests that osteoporotic changes. And in the X-rays of hand, the both hands, left hand and right hand, both have almost the similar figures, where we can see the osteoporotic changes even in the hands of the left upper limb, and especially in the medial border, there are, even though it is not it is seen in the fourth finger, where we can see, sir, medial margin, the bone appears to be eaten away. This is one of the characteristic features.
Typical appearances of parathyroidism.
Yes, sir. Typical appearance of a parathyroidism.
Is there any distal resorption?
Sir?
Distal phalanges, is there any absorption of the tip?
Yes, sir. Slightly the distal phalanx is also resorption is there.
Okay. So you are virtually sure what this is going to turn out to be.
Yes, sir.
Go on to the next. What about his lower limb? He had a pain immediately after sleeping.
I'll show that also. Sir, and we can even see there is a fracture in the fifth metacarpal of the left hand. However, the patient did not give any history of any trauma or anything. So this is a pathological fracture in the left.
And the bony changes are both osteoporotic or osteopenic. I don't know what is the correct term in hyperparathyroidism, and osteolytic. See here. Here you can see in two of the metatarsals, you see these osteolytic changes.
Osteolytic changes.
That pepper pot appearance also, which Dr. Desai corrected you, is because of osteolytic changes, that there are small osteolytic lesions. So both probably are there, osteoporosis as well as osteolysis.
Yes.
Yes.
Sir, and also in lower limb, where we can see there is osteoporotic changes and osteolytic changes in the right lower limb. I mean, it is seen in both lower limbs, sir. In the tibia and fibula, distal fibula, we can see the osteolytic changes are also seen.
Yeah.
And Dr. Vinay Mahala says that you can even see osteoblastic changes. So all these changes may be seen.
Okay, sir.
Yeah.
Yes, sir. So these are the same findings I have mentioned. And the
Don't
patient,
have to reread them. Go on, move on to ultrasound neck and.
yes. So ultrasound neck has shown diffuse thyromegaly, multiple hypervascular nodules in both lobes of thyroid, with thyroids of 2, and hypoechoic hypervascular nodules along the posterior aspect of both lobes of thyroid, largest being 19 by 12 by 12 mm in the left superior aspect. So he was evaluated.
So what comes to mind?
Sir, the first thing I would like to think is about a parathyroid adenoma. All 4 glands are enlarged.
So if all 4 glands are
enlarged,
enlarged,
Men's syndrome?
Yes, sir, Men's syndrome.
What about medullary carcinoma thyroid?
Sir, medullary carcinoma thyroid nodules won't be seen also. And
it will be either unilaterally involved or it will be a diffuse thyromegaly.
Sir, it is a diffuse thyromegaly, but in this patient, there is specifically both lobes have vascular nodules. That is what it is mentioned in ultrasound.
How many of them? 4 or less or more?
Multiple, sir. Multiple.
So multiple does not mean parathyroid, because parathyroid will be usually 4 to 6 in
yes,
number.
Yes, only 4. Yes, sir.
So what are the other lesions? What other lesions in the thyroid can be there? In case of in the context of Men's syndrome,
yes,
the only possibility is MEN2, and it is showing medullary carcinoma thyroid changes.
Okay, sir.
And in that, you can have one nodule or you can have diffuse involvement.
Okay, sir.
Is there any history to suggest medullary carcinoma of the thyroid, like diarrhea?
No, sir.
Bony pains?
No, sir. Bony pains. Bony pains were there, but no.
Medullary carcinoma of the thyroid wouldn't produce bony pains because it produces calcitonin.
Okay.
And calcitonin is working against parathyroid hormone.
Okay, sir.
So he wouldn't have all these extra changes. That is the thing.
Yes.
1 or 2, if they had been there and they were large, we would have considered either brown tumor or you could have considered metastasis.
Okay, sir.
But from your description of the X-rays, there is no evidence to suggest brown tumor. Is there any evidence to suggest that the femoro-capital angle is reduced? Because the bones are very soft, they start bending.
Yes, sir. Actually, patient is having valgus deformity on clinical examination only.
Yeah. So it's in support of osteoporosis.
Yes, sir.
Because of parathyroid hormone hypercalcemia.
Yes, sir.
Yeah. Go ahead.
Sir, as I know the history and all the imaging, sir, there is a brown tumor visible in the maxilla, the X-ray of this face or the skull bone. There is a brown tumor, visible brown tumor in the maxilla, sir. It is retrospectively seen because we have seen the further imaging. So if you want to, Krishna,
yes,
go back.
There is CT scan of neck also in that you mentioned.
Skull.
There are multiple lytic sclerotic lesions in the maxilla and mandible bilaterally. Pepper appearance of skull and sclerotic vertebral body.
X-ray.
X-ray, sir. Okay.
Skull X-ray. Yes. If you can see, this is side. They are showing the brown tumor. You can see my point.
Yeah, in the maxillary.
Yes, sir.
Mandibular and maxillary.
Further imaging, this is retrospective.
The one in the front might not be a brown tumor because it could be just a focus of osteoporosis. But in his craniofacial complex, there is some areas of loss of density that you can call as brown tumor because they are larger. But the one in the mandible is not a brown tumor because that's the normal morphology of the mandible when you see a lateral view.
Yeah, in the maxilla later on they said that it is probably a brown tumor. Okay,
Yeah.
please carry on.
Yes. And the CT scan of 4-day CT scan of neck was also shown heterogeneous enhancing mass lesions posterior-medial to both thyroid lobes, which is 16 by 20 by 30 on the right side and 13 by 12 by 19 on the left side. And fat planes are lost with the thyroid glands. Multiple enlarging heterogeneously enhancing nodular lesions in both lobes of the thyroid, with largest being 24 by 26 and multiple mixed lytic and sclerotic lesions in maxilla and mandible bilaterally and pepper skull of appearance, sclerotic vertebral bodies. Impression they have mentioned it to be a brown tumors.
So this is the point which Dr. Vinay Mahala was saying, that you can see both lytic as well as sclerotic lesions.
Sclerotic changes.
Yes.
And what triggers sclerotic changes is a fracture. If there is a fracture in these brown tumors, they start calcifying. So sclerotic lesions should not be taken as a sign of normality, or they should not be taken as a benign change. Usually it indicates fracture in the brown tumors that has produced the calcification.
Yes. So in view of his past history of pituitary tumor surgery, MRI of sella with contrast was also done, which was showing a focal lesion in the anterior lobe of pituitary gland with the size of 11 by 9 by 9 effacing and displacing the adjacent parenchyma medially and mild displacement of pituitary stalk towards the left side. Lesion is showing relatively less and heterogeneous contrast uptake compared to the rest of pituitary parenchyma, suggestive of residual pituitary macroadenoma in the impressions.
I don't know how you're saying there is a focal lesion in the anterior lobe of the pituitary gland after a total pituitarectomy transsphenoidal routine.
Sir, we do not have the complete no documents were also there for with the patient, sir. So we don't have the biopsy or any.
Possibly a partial resection with the left behind tumor, which is growing now.
Yes.
Or microscopic. Yeah. Okay.
And you could say that the hormone levels were not low. He was not on any replacement therapy. So these are also indirect indicators that probably it was not a complete removal of the pituitary.
Yes.
MRI also was done. What did the MRI show? You showed the MRI report.
MRI, we do not have the films at the films.
But it shows the same findings.
Yes, sir. This is not the MRI. Sir, you can see the triple phase CCT, sir. This is the triple phase CCT arterial phase, in which
not yet.
Yes, sir. We can see an arterial enhancing lesion nearly in the 5th segment of the liver, and along with that there is a arterial enhancing lesion in the head.
We are not able to see.
Not able to see. Okay.
No. Yes. Now.
I'm not able to play this, sir.
Do you have a file?
The video has to be in the same folder as the presentation.
I have a video in the computer. I can.
I think show the primary video.
Yes. Sir, the video visible, sir? Is the video visible?
No, we are still seeing your slides. I think you have to.
We're seeing a black rectangle.
Stop sharing and then share again and then play the video.
Okay, sir. Sir, you can see now.
Yes.
Yeah.
Yes, sir. This is a portal venous phase of the triple phase CECT, in which we do not see any enhancing lesions in the both lobes of liver. However, there is a mass lesion where we can see in the head and neck junction of the pancreas. Sir. Other lesions which are we cannot.
Is it infiltrating the vessels? Is it
No, sir. It is
infiltrating
not
the
infiltrating the vessels. It is.
iliac axis and superior mesenteric axis?
Yes, sir. It's.
Is it extending into the retroperitoneum? Why
No,
am
sir.
I asking these questions?
We have to. I mean, this decides the plan of management in the patient now.
Not just the plan of management, but it also indicates malignancy.
Yes, sir.
So it means the prognosis is poor and you should look for metastasis in lymph nodes and elsewhere. See, pepper pot skull can also be produced by multiple tumors in the skull region. So if there are multiple bony metastases,
Okay.
you can get a similar appearance.
Yes.
So it seems to be a very large lesion which spread into the retroperitoneum, from what I can see. So we will take it as a malignant tumor.
Yes.
It's not, it's in the venous phase, so I can't comment anything.
Yes.
We
Now,
need the early arterial phase to see whether it is enhancing.
Yes. Sorry, this
Actually,
is
when you are trying to show a neuroendocrine tumor, you should show the arterial phase first, because that is where the tumor will
Because
be.
it will be brilliantly transilluminating in the arterial phase.
arterial phase. So, this is the arterial phase image, sir, in the CECT. In this image, we can see a enhancing lesion near the segment 5 of the liver, which will be coming now in the arterial enhancing lesion. Yes, sir. We can see arterial enhancing lesion and peripherally enhancing lesion. Enhancing lesion with more enhancing in the periphery in the head and neck region. And multiple lymph nodes, necrotic lymph nodes are also seen. Sir. Necrotic lesions are also seen in the intra-aortocaval region.
Yeah.
Yes.
The pancreatic lesion is not in the head and neck. It is in front of the neck, more towards the body rather than towards the head of the pancreas.
Okay. So the report they have
It appears to be adjacent to the duodenum. That's why I have been saying it's in the head.
Actually, here we probably did not appreciate, but they showed a separate lesion on the right wall of the second part of the duodenum, a small lesion, but this main lesion is in front of the neck of the pancreas. And there are a few nodes, large nodes behind the head and uncinate process of the pancreas, which have some process inside.
Yeah, sure, sir.
So in the report they have mentioned the heterogeneous enhancing mass in the head of pancreas, which is 35 by 47 by 39 mm, abutting the splenic vein, which is opacified, and posteriorly the splenic vein is abutted, and stomach, it is anteriorly abutting the stomach. There is a tiny calcific focus seen in the periphery of the lesion, which shows patchy enhancement on arterial phase. And there is contiguous extension of the mass lesion into the adjacent gastrohepatic region, which is measuring around 26 by 33 mm. The pancreatic duct appears to be anteriorly displaced and no upstream dilatation of pancreatic duct. There is another and tiny arterial enhancing nodular lesion seen in the head of pancreas along the anterior superior aspect of body, measuring around 10 to 11 mm. The fat planes with SMA is maintained. Another arterial enhancing lesion of around 15 by 18 mm seen in the segment 5 by 8, and another 5 to 6 mm enhancing lesion is seen in segment 6 of liver. The second one we couldn't identify in the CT scan video. The suspicious tiny arterial enhancing lesion along the lateral wall of D2 by D3, which is 6 to 7.
What does this suspect? What do you mean by suspicious small lesion? What sort of tumors produce that kind of small lesion in the duodenum?
Sir, one neuroendocrine tumors.
Second, of which type?
Of which type?
What hormone secreting?
Sorry, sir.
What is gastronoma triangle?
Gastronoma triangle, Passaro's triangle, which is the junction of cystic duct and common hepatic duct. Line joining 3 lines, cystic duct, common hepatic duct point. Second is head and neck. Third is D2, D3 junction. This is
so is this within that area?
Yes, sir.
So if it is within that area, what tumors can you think of?
Gastrinomas.
Yeah, so that comes to possibility. And what percentage of gastrinomas are malignant?
More than 50%, sir. About two-thirds, more than
almost
two-thirds
70% are malignant.
two-thirds, yes.
So that's what we can come at with this amount of presentation. That's what we can come at in terms of the diagnosis. If there's any more evidence, you can present to us.
Yes. Along with that, there are multiple nodular lesions with internal necrotic areas in the pancreatic or renal groove, which are necrotic lymph nodes, which is largest is 19 by 15 mm. And the right kidney is, left kidney is smaller in size compared to the right. Bilateral cortical cysts and multiple small calculi also seen. The CT scan has shown multiple lytic areas in both, all bones, sir.
Yeah, okay. So what is your final diagnosis?
So this case is most likely to be a case of Men's syndrome type 1, right now presenting with metastatic pancreatic neuroendocrine tumor, most likely a gastroenteroma.
Okay.
Yes, sir. It's an incomplete men.
What about the pituitary tumor? What is the pituitary tumor doing?
Sir, it
What
is
do
a
you think
pituitary macroadenoma, which is residual tumor or recurrent tumor, which I cannot.
You are assuming it's the person would be an expert and would have done his job.
Okay,
So you have to always say recurrence. Don't give a bad opinion about the other physicians who have taken the diagnosis.
okay.
Every physician should be considered competent unless proved otherwise.
Okay.
Yeah. So you should never say it was incompletely removed because you have no evidence.
You
If
should
you
say
had
diagnosis. You should say multiple endocrine neoplasia currently presenting with because all the three components are there based on the investigations and imaging. So why do you say most likely gastrinoma? Serum gastrin level is so high. It is a gastrinoma. And there is a suspicion of malignancy because there are nodes. There is a liver metastasis, which is also hyper enhancing. And there is a recurrent or residual pituitary tumor. And there is strong suspicion of parathyroid lesions. I don't know if you see two enlarged parathyroids, whether we are waiting for Dr. Kasriwal to come and clarify this point with him, because as far as I remember, adenoma is single, but if you have multiple parathyroids enlarged, it is more likely to be hyperplasia. But let him come and clarify
that's correct, sir. But this is Men's syndrome. Being Men's syndrome, you can expect multiple parathyroid tumors.
Okay.
That is the thing. But one thing, why didn't you do a MIBG scan?
Sir, MIBG scan, sir. We want
meta-ido-biguanidine scan.
Yes, sir. So it is a metabolic scan where the tumor cells are there. There will be uptake. We can identify the wherever, even the mets, any liver mets or bony mets. In the primary also, this uptake will be there.
Yeah, and it will show a parathyroid lesion basically.
Yes.
Yeah. So has it been done?
No, sir.
Okay. Are you planning to get it done?
No, sir. Right now.
Why no?
Sir, we can directly parathyroid. Yes, we need to evaluate the parathyroids. Okay.
Are the parathyroid infiltrating into the thyroid parenchyma?
Yes, sir. They are infiltrating the thyroid parenchyma.
So it's a malignancy of the parathyroid straight away. You need not have any doubt. You need to do a meta-ido-benzyl guanidine scan to make sure that it is not. There are not other additional parathyroid tumors in the superior and anterior mediastinum. And also whether the metastases are from parathyroid carcinoma or the metastasis from the pancreatic tumor, which is more likely.
Okay, sir.
So what will be the priority of management? Because he has multiple problems.
Yes. So the first priority is the parathyroid gland. Because the two reasons. One is serum calcium level is hypercalcemia is present for this patient. Second is general conditions. Because of this osteolytic lesions, the patient hardly can sit properly. So first we need to correct the parathyroid problem, and following which then once the patient improves, we can plan about the further management for the pancreatic neuroendocrine tumor.
Yeah, so I think parathyroid has already been
Removed.
reviewed.
It's removed.
What
How
did
was
they
it
do?
removed?
Sir,
Parathyroid was
Sir,
removed.
parathyroid surgery was done by our endocrine surgeon here. They removed all four parathyroid glands. As the discussion with them, they suggested there is a highly desmoplastic reaction was there. So she has to take approximately around 5 to 6 hours to remove all the four parathyroid glands. So but it was a difficult surgery for her. And thymectomy also.
Have they biopsied this area of extra fibrosis for metastatic lesions? Because
I think
it is looking like a metastatic.
it was done just a few days ago, so I don't think we have the final histology.
Yeah.
But I don't think that it has been treated like a parathyroid carcinoma. I think it has been treated as a adenoma or hyperplasia. And as you pointed out, that sometimes there are parathyroid tissues in the thymus, so they've done a thymectomy also.
Okay.
So, what will be your plan? Suppose this is all done and parathyroid does not show tumor and the serum calcium returns to normal as is expected. What problem is expected, metabolic problem, when you have such high serum calcium and you have removed all four parathyroids? What do you expect?
hypocalcemia in the post-op periods.
Yeah, so this is called the
Hungry bone
hungry
syndrome.
syndrome, that bones then start taking up calcium and actually the patient can go into hypocalcemia, and a close watch has to be kept on serum calcium level. Okay, so after say a couple of weeks, the calcium levels have returned to normal and they are stable. What is your plan for the pancreas?
Sir, I would like to do an imaging in the form of no, sir. Somatostatin receptor scintigraphy to see other areas of metastasis, whether any bony mets were there or not. I have to see.
How is that going to change your management? You already have liver metastasis. Most probably there are lymph node metastasis also.
Yes, sir.
So whether two metastases are there or more are there, how does it make a difference?
Sir, only if the disease is limited to the liver and the number of lesions is less than 50% of the tumor volume, debulking surgeries will have. Sir?
Debulking should come as last. You should basically try to resect curatively.
Yes, sir.
And do a radical pancreatectomy and removal of the liver metastasis.
Yes, sir.
And put them on long-term lanreotide.
Yes, long-term lanreotide.
Yeah.
Neuroendocrine tumors and few other tumors like renal cell carcinoma, to some extent CA breast also. These are some conditions where even in presence of metastasis, resection is not contraindicated. You still try to resect, and as Dr. Desai said, your first aim has to be an intent to cure R0 resection, which means that you deal with the pancreas, you deal with the liver, and then put the patient on hormonal management. So I'm not sure whether an SRS at this stage would change our plan of management.
Okay.
And maybe, Rajen, what is your opinion? To some extent, he may be right, because if SRS shows widespread metastasis, then
it becomes a palliative debulking.
Yeah, then probably a palliative but still resection.
But the point with somatostatin scintigraphy is it is very poorly functional as compared to a DOTATAC or a DOTANOC scan. So you should do either a DOTATAC, DOTANOC or a DOCTET scan for extra pancreatic metastasis. I wouldn't do somatostatin nucleus scan, because the resolution of the gamma camera is such you can't really make out.
Okay, suppose we have done a DOTATOC scan and it does not show other metastasis, only the liver is there. So what will be your approach?
Sir, first, the patient is medically fit to operate.
You have completely evaluated the patient. Now you know whether he is fit or not.
Yes. So
I think he needs a PET scan as well.
Yes.
You need a PET scan as well, because DOTATOC or a DOTANOC are for specific receptors in the somatostatin receptor group. So if that is absent, then that will be a negative test. But if you do a PET scan, and if the lesions are more than 1 centimeter, you can visualize that in PET scan.
Yes.
Yeah,
So,
so surgery, you tell us.
yes, sir. Sir, if the patient is having, operable, then we will go for R0 resection. In pancreas, we can go for, we'll do Whipple's procedure, and along with that, all metastasis in the liver will be removed.
Dr.
So
Kapoor
this
was
one-
saying it is extending into the neck of the pancreas. So how will you do a Whipple's?
the neck of pancreas.
Do you have a static image of an axial cut of the CT?
I have not taken static cut.
Because Anand, am I right that it was not in the head? It is at the junction of head and neck and more towards the body, if I remember correctly. So in that, suppose with that description, what will be your surgical procedure on the pancreas?
If you didn't have the lesion in close to the duodenum, what would you do? And if you had the lesion close to the duodenum, it could be a lymph node that is involved. So there are various possibilities.
Okay.
So you tell us what you will do.
Because if you are planning a pancreatoduodenectomy and the lesion is sitting in front of the neck of the pancreas,
Yes.
then you have to say that it will be something like an extended pancreatoduodenectomy where you will have to go into the body of the pancreas to have at least a gross clear margin.
Okay.
Which means it will be more than the usual pancreatoduodenectomy.
Pancreatic.
But suppose I tell you that the head of the pancreas is free, the tumor is lying in front of the neck of the pancreas more towards the body, then what could be a possible surgical procedure?
Sir, it depends upon the size of the tumor and distance from the PD. Central pancreatectomy is theoretically an option, but it is not possible in this patient. It is close to the PD, sir. The pancreatic duct is quite close in this case.
So close to PD is a contraindication for central or median pancreatectomy? It is a contraindication for enucleation, not central pancreatectomy. Central pancreatectomy means you are removing the entire thickness of the pancreas on this side and on this side. So PD obviously is sacrificed. What you are saying is in relation to enucleation, which anyway is not a procedure for gastrinoma, because as Dr. Desai said, that majority of the gastrinomas are malignant. Enucleation is only for an insulinoma. Which are benign in almost 80 to 90% of cases, and then the proximity to the main pancreatic duct becomes an issue. So here, for central or median pancreatectomy, even if the PD is involved, you can still do it. So you are not right in saying that. Okay. So Aman wants to know: can we mention central pancreatectomy for a frank malignant tumor? See, this is a neuroendocrine tumor as opposed to an adenocarcinoma. And even in adenocarcinoma, if you can get a margin, if the head is completely free and you have good amount of pancreatic parenchyma in the body and tail, you have all these options. Although generally you would either extend a distal pancreatectomy more towards the head or a pancreaticoduodenectomy more towards the body and tail. And in this case also, at one stage, we even thought that if the head is free and if the remaining parenchyma in the distal body and tail is small, whether you should still do a distal pancreatectomy. So that would depend on the intraoperative assessment. But the margins of adenocarcinoma versus margins in a neuroendocrine tumor would probably not be the same. Rajendra, would you agree? Ajay, what is your?
I agree, sir. Yeah, that's true.
But metastases are there.
Aman is asking, it is already metastatic. Would you do a central pancreatectomy in such cases?
Yeah, that's what
Ajay
yes. is trying to answer.
Yeah.
Solitary lesion in the region of body of pancreas, no nodes disease, no metastasis, then definitely you will likely do a central pancreatectomy. Maybe after resection, you will get a tissue diagnosed that it's malignant. And beforehand, definitely, if you have a PET scan which is not showing any evidence of metastasis, central pancreatectomy is always an option. For any lesion in the body of pancreas which is not having any lesion anywhere else. And if it's resectable, obviously this is the most viable option and this is the most practical option which should be used.
But what about in presence of documented metastasis?
Then no, then why should you do this?
Yes, Aman, you should do a complete node removal. Whether it's curative or not is not the question. This patient has high gastronoma levels already. He'll end up with multiple duodenal and jejunal ulcers, which may perforate and he may do badly. So that you have to debulk as much as possible. If you're going for the debulking procedure, curative procedure, you be as curative as you can and then wait for the histopathology to come back and tell you more.
Okay, sir.
I think we can do a central pancreatectomy in that case, because if you are getting both the margins to be clear, and nodal clearance become much more easier once you have done a central pancreatectomy as compared to when you are doing any other mode of pancreatectomy, because what nodal clearance you are doing is around the vessels which you have already looped. So clearance along the HDL or into the aortocuval nodes or into the to the superior mesenteric artery becomes much more feasible when you have done a central pancreatectomy. So I don't think that nodal clearance will be a problem in this, and nodal clearance will be helped when you are doing a central pancreatectomy. And central pancreatectomy, the main intention is that you preserve as much of pancreas, remnant pancreas, possible for the subsequent life. So I think that will be, if it is feasible, it should be done.
Yeah, that is an approach I agree with.
Rajen, the discussion we had along with the endocrinology and other radiology was that most probably we will not be able to remove all the disease burden here, because in addition to this tumor, as I mentioned, there was a small tumor on the right wall of duodenum. There was another small lesion seen in head of the pancreas.
The small lesion in the duodenum can be operated like a wedge.
It can be removed.
And can be removed. You do a central pancreatectomy, do nodectomy, lymphadenectomy as much as possible, do a liver resection, and then wait and watch. See if the
put the patient on long-acting.
lanreotide.
Yes.
Lanreotide has an anti-mitotic effect as well as a hormonal effect.
Hormonal, yes.
So it is useful.
Aman wants to know, while undergoing parathyroidectomy, can he be put on PRRT and lanreotide in the meanwhile? Yeah, I suppose you can. You can. Because as Dr. Desai said, that gastrinoma with such high gastrin levels, although so far we haven't done an upper GI endoscopy, but it is very likely that he will show multiple ulcers and ulcers at unusual sites. And these patients are at a risk to have complications, either bleeding or perforation. So that is why it is important that while they are waiting, they are covered with the high dose PPIs, and maybe, as Aman is saying, that while waiting, he could be on hormonal management also. So I think we are already beyond 10, so we will close. And thank you, Rajen. Thank you very much.
Thank you, sir. Thank you.
Okay.
Thank you, sir.
Krishna, for a very interesting case.
Yeah, thank you.
Thank you.
Yeah, this is one of the classical manifestations of an MEM. Thank you, GV. Thank you for joining. GV was my colleague in AIMS. He recently retired.
Thank you very much, sir. We are together. Desai also was there in Nijams along with me when I was there in Nijams. So I was in Usmania before. So thank you very much, Vinay sir, for giving a chance to listen to what been an excellent discussion of high grade, totally different the status today's. Learned a lot of things, new things. Thank you, sir.
Thank you. Thank you.
Thank you, Desai. Thank you.